Finally, we're done with all the physics and technical stuff. It's time to learn how to image. So this chapter is probably one of the most important chapters of the entire course because, after all, it depends on whether or not you're able to display pathologies if you can diagnose them. Let me tell you a story. Some time ago, I was holding a hands-on course and there was this one guy who was desperately trying to get good images, but he simply couldn't. The images he got were absolutely terrible. However, he tried. He did get better a little bit, but he still sucked. Well, what happened? I was holding the same course again in a different location and he was there as well. Again, sitting, trying to image, not much better, maybe a little bit better. Then one day he called me up and said, well, maybe when you're on call, can I come in and I'd like to image some patients just so that I get more practice? I said, yes, why not? So he came in and he got better and better and better. In the long run, he is now one of the best echocardiographers I know. And I can tell you that he really, really excels. What is the key message here? Simple. It's not only about talent. It's much more about how much you try and how much effort you actually put into learning how to image. I mean, after all, echocardiography is not an acrobatic act. It's a simple skill that you can definitely learn, that everybody can learn. And practice is also my very first tip if you want to learn how to image. The second is experiment. So see what happens if you move the transducer in one direction or another. Store images and write a report. This is probably one of the most important features or tips that I can give you, because if you don't do that, you will not get better. You will not be pressed into getting better images and to really think what the patient has. Be patient. It takes time. And take your time when you image the patient as well. Know anatomy. We'll show you a lot of anatomy during this course, so you have to know where the structures are to be able to recognize them. Position the patient. What does that mean? Well, you can get a lot out of putting the patient in the right position. You will get better images that way. This is something that is equally important. And don't give up. It takes some time, as I already mentioned, and nobody starts being an expert. Everybody has a learning curve, and as you go along, you will see the learning curve will get steeper and steeper. Let's start with the transducer and let's see what is important here. So this is the transducer that we're using for cardiac imaging. As you will note, it has a fairly small footprint, which is very important because we need to get right in between the intercostal space. Another important feature is that we have a marker. This marker allows us to always know where we're actually orienting our transducer on the image. Now, if you compare this transducer with this transducer here, which is a curvilinear transducer that we use for abdominal scanning, you'll recognize it looks quite different. In contrast, this is a classic linear transducer that we use, for example, for the carotids. It's important that you really take care of the transducer because it's a very sensitive part, and if you drop it or if you break it, they're very expensive. They cost something in the range of over 15,000 euros. And if you have a 3D transducer, they might be even more expensive. When you learn how to play tennis, the very first thing that is taught to you is how to hold the racket. And the same thing is true for the transducer. So here we go. So how do you hold the transducer? It's very important to hold the transducer further down, very close to the footprint. What I always do is I always use my little finger and kind of fixate the transducer by putting it in such a position. And to have a firm position of the transducer on the chest, it's important to rest your entire arm on the chest of the patient. Then you place the transducer, and with the little finger, you more or less fix the position. This is very important because if you hold the transducer somewhere here, you'll eventually lose the position and you will not get a good image. What we show you in this course is imaging with your right hand, but I'm well aware that many of you probably image also with your left hand. There's not much difference. The advantage, of course, if you image with your left hand is that your back is a little less under strain. The disadvantage is that most people are actually right-handed, and it's probably easier to start learning echocardiography with the hand that you're used to working with most. Still, when you image with your left hand, be aware that you have to adhere to the very same rules. Again, try to stabilize the hand on the body as much as possible. Okay, now let's take a look at how you should actually move the transducer on the chest. So there are several ways to steer the probe. The first maneuver you can perform is you can slide the transducer along the chest. Usually you want to get within the intercostal spaces, so you can slide up and down. The second motion you can perform is a rotational motion, something like this. And the third is that you can tilt the transducer. Now, of course, if you tilt the transducer, you will sometimes have the footprint not touching the skin. How do you prevent that? Well, one thing, you have to use a lot of gel. And the second is you have to apply at least some pressure on the chest. Obviously, also depending on whether or not the patient has enough subcutaneous tissue or not. So as a summary, there are 3 movements. It's rotation, where you rotate the probe on the chest. It's tilting the transducer, and it's sliding the transducer up and down the chest. Of course, you need a lot of gel, and that will also help you when you want to do these maneuvers. Now, of course, when you image patients, one of the most difficult things is to really image the structures which are behind the rib. And this is especially important if you have slim patients. And to get good images, here you need to angulate the transducer from the intercostal space to visualize behind the ribs. Now, everybody always says, don't image on the ribs. This is only partially true because you can't put the transducer kind of slightly on the ribs or on the corner of the ribs and image very, I would say, oblique to get behind the intercostal space. So this is what I'm displaying here in this image. Remember that. It's very important. So if you rotate the transducer, you're always going to rotate around the midline of the sector. Bring the structure you want to rotate around exact in the middle, and then you will get all the different views of the structure. I mentioned that there is a marker on the transducer, and it's available on every transducer, no matter if you're using brand A or brand B, or if you're using transesophageal echocardiography. So you will always find a marker, and that will tell you where exactly your orientation is. Sometimes these markers have a letter, or sometimes they brand the machine. This is a secret way for the vendors to promote their images. And as a matter of fact, it's something that you will easily be able to recognize. I'm frequently asked, how firm should you actually place the transducer on the chest? Well, in the following demonstration, I'll give you my take on this issue. Well, you have to at least apply a medium force so that you at least dent the transducer into the body or into the tissue of the patient. That assures you not only that you have a good contact, but also it stabilizes your position to some extent. But I know that different investigators use different force on their transducer. I guess you'll just have to ask your patient. If it starts to hurt them, I guess you're just applying too much pressure. I guess you realize that the model we're using in the demonstration has terrific image quality, and the imaging window is very, very large. But at times you will have problems with the lungs. In the following demo, we're going to demonstrate what happens to the image if a patient inhales. Air is one of the biggest enemies of ultrasound. And very frequently, you'll have air interfering with your image, especially from the lung. Let me show you what happens if I ask my patient here to inhale. All of a sudden, you will not get a window. All you will get is the strong reflections from the lung. But you can use the respiration to your advantage. Ausatmen. And all of a sudden, you will get a much better image. The other thing you can do is you can optimize your image window so that you're not even close to where the lung is. And that obviously also gives you a much better image. When someone inhales, it's not only the lungs that inflate, it's also the diaphragm that moves. And this motion can also assist you if you want to get good images. There will be situations where it's actually better to ask the patient to inhale, especially in a 2-chamber view. Let me demonstrate that. All of a sudden, you will see a much better 2-chamber view. Sometimes you will have to adapt the level of inspiration, but I guess you can clearly appreciate that you have a better appreciation of the anterior wall here in this 2-chamber view. The position where you place the transducer for the individual windows can vary greatly depending on the somatotypes of the patients. For example, if you have a patient who is more ectomorph, the heart will be positioned more towards the midline, often behind the sternum. That's why you have to place the transducer again more towards the midline, and sometimes also more caudal. If you have a patient who is a mesomorph or an athletic type, then the position of the transducer will be kind of in the middle. It will be probably in the apical region in the mid-clavicular line, somewhere in the middle of the chest as well. If you have a patient who is very obese and where the diaphragm is more cranial, you will have to image the patient also more cranial, and frequently the apex of the heart is more lateral, and sometimes it can even point to the back. So keep this in mind, and if you're experienced, if you see a patient, you will immediately know where to actually put the transducer. Is obesity in imaging a problem? Well, certainly it is, because usually the heart is further inside the body, so you have to use an increased depth, which basically reduces your image resolution. Now, still, if you have patients who are obese, but they have a lot of body fluid, in other words, the juicy obese patients, sometimes you get quite good images here. It's more the elderly obese patients and those patients who I would say have emphysema or other comorbidities as well that are more difficult to image. If you have very slim patients, it might be even more difficult to image these opposed to someone who is obese. What other problems might you have? I guess everybody who works in a busy echo lab and has a cardiothoracic department or maybe even a traumatology department knows the problem. Patients come in with all sorts of injuries, bandages, where it might be very difficult to image. Of course, the advantage is that you can use multiple image windows and frequently you will get at least some view to the heart. But clearly there will be patients where you cannot get the best of images. Another problem is patients who have, for example, Holter monitors. How do we handle that? Well, we prefer patients not to have them, but if they do have them, as I already mentioned with the patients who have bandages, there is a way that you can see the heart. Sometimes it's even necessary to image patients in a sitting position, for example, if they're in a wheelchair. That's possible as well. A problem that we're sometimes confronted with are breast implants. Breast implants are more difficult to image because they, of course, obscure the view to the heart, and they sometimes appear as if the patients have a pleural effusion. I think patients who get breast implants should actually be aware of this limitation. These were the basics of imaging. In the following chapters, we're going to go through the individual imaging windows and show you what standard views you should acquire.